webinar. I'm very happy as you all know, the PG forum was started by our president, Dr. Respected President Dr. Alpesh Gandhi, and myself, Dr. Charmila, Rohan, Priyangur, and Harika, we are the coordinators for it. So every month you are seeing us. Some months we have two programs. This month we have two programs. One today and another on Thursday. Coming to today's program, today, as you all know, today's program we have stress urinary incontinence. It's a very important topic. 2 days back, Kerala KUHAS, that is our Health University question paper, also stress urinary incontinence was asked as 10 marks question. So it's a very frequent question, not only for the exam and for the oral exams also, theory, oral, and a very practical topic for your practice. So most of the patients with one of the common complaints in the gynec patients are having is a stress urinary incontinence. So first you have to know what is, how to diagnose it itself. Is it a true stress urinary incontinence? Previously, many incontinence which were not stress itself were managed with TVT and all these things, and complications where patient landed up in urinary retention and all. So now we are, so today very important topic for your practical purpose also. So today we have an excellent speaker, and I'm very fortunate to have Atul Seth sir. One word I will tell you. I met Atul sir 5 years back, 5 or 7 years back, in a PG quiz I was conducting. So the enthusiasm with which he was sitting as an audience and not only answering, for encouraging his PGs to score marks. So I understood a teacher, passion of teaching, a teacher. That is what teacher always gets pride when a student tops. So now also, whenever his students gets good praise, and always he sends a message that my student got first in this. That is what Atul sir is. So I wanted to introduce Atul sir to all of you, not only as a teacher with a passion. And about Atul sir, we have my co-coordinator Charmila, you know, the past chairperson of Clinical Research Committee of Fox, and she is a consultant from Trichy, and she has so much awards and publication to her. Not much you all know. Every time I introduce Charmila, so it is one part. She is also a part of our PG forum. So I want Charmila now the mic to Charmila to introduce her, and she will take over the discussion also at the end. So Charmila, the mic is yours.
Thank you, Ashwath sir. Thank you so much for that. And it's a great honor that I have got to introduce a great teacher, as you said, one who teaches with passion, Dr. Atul Seth, to the audience. He's a professor and unit head Department of Obstetrics and Gynecology at AFMC Pune. His field of special interest is in urogynecology and minimally invasive surgery. And as sir said, he's very passionate about teaching. And I could see a smiling emoji also. So he enjoys the teaching and he does it so much passion. It's a great honor that you're with us today. And his other passion is cycling. The honors and awards he's won are many. He's won the United Nations Force Commander's Commendation, GOC&C Southern Command Commendation, the Director General of Armed Services Medical Services Commendation. He's got an international experience and he's worked with the United Nations Peacekeeping Force. He's worked on fistula surgeries. He's got several publications in national and international journals, and he's a faculty at national and international conferences. Welcome, sir, for this PG forum. We would like to listen to you on your talk on SUI. Thank you so much for attending our program. Thank
you. Good afternoon, respected Dr. Ashwath sir, Dr. Charmila, and my dear students. So I am actually humbled by the very elaborate introduction. I do not know if I deserve so many adjectives which sir used and madam used, but yes, I am certainly looking forward to a very interesting teaching and learning session. Why I call it teaching and learning is that, whenever you teach, we learn. The same topic we may have read so many times, taught so many times, but it is our students who will, so many times come up with questions, their queries and things, which even after so many years take us by a little bit of surprise, and we have to go back to the book and read up again and come back to them. So it is teaching and learning both ways. So I think if I have your permission, can I start, ma'am?
Please, sir. Yes, sir.
Yeah.
Sir, start, sir.
Yeah. Okay. So, good afternoon to all of you. My dear students, today the topic on which we are going to talk is stress urinary incontinence. And at the outset, I bring you regards and best wishes from Department of Obstetrics and Gynecology at Armed Forces Medical College, Pune. I'll be conducting my talk under the following heads. Firstly, why are we talking of urinary incontinence and in specific about stress urinary incontinence? A part of this, Dr. Ashwath has already told you that this is something which is a very common clinical condition. As we go along the lecture, what you will see is that how common it is. And when I talk of urinary incontinence in women, I like to call it the silent tormentor. There are large number of women who suffer from this problem, but from factors which we are going to discuss, they just keep quiet and keep it to themselves and keep suffering quietly. SUI, that is the stress urinary incontinence, is one of the common types of urinary incontinence that we encounter. And as we all, the residents, we are students, we also have to keep another factor in mind. That is that, how it affects our prospects in the exam, in the long case, in the tables, and the theory paper also. So as Dr. Ashwath was saying, this is nowadays a commonly asked question in the theory. Not only that, whenever you have a case of, let us say, uterovaginal prolapse, now that is a common case which you get in the exam, and it is quite possible that if your patient along with the prolapse has history of urinary incontinence, your entire viva on that long case may be just on the stress urinary incontinence part, because it is so very common. And we are all, as specialists in obstetrics and gynecology, expected to know about this. This is not a topic anymore which is specialized to a urogynecologist. So that is the reason why we are discussing about urinary incontinence or stress urinary incontinence. So we will be initially giving you some definitions. Then we will be talking about anatomy and physiology, how to take the history, examine the patient and order investigations, how to treat these patients, and what are the recent advances. Last but not the least is tips and tricks. Now, this last point that you see is in red color. Now, whenever I move my slides and you see something in red color, I will keep telling you also. So that is something which you have to, those who are writing down or recording, remember that that is a little special point for you as a PG student, which may be asked to you in the viva, or when you are answering well, the examiner wants to give you some more marks, so they may ask you a little more difficult question, and that is where those tips and tricks come into play. And that is what I'll keep telling you all along, and all those points will be in red color, right? So coming to the definition. Now, how do you define urinary incontinence? So urinary incontinence is a demonstrable, each word is important, mind you, fine? Demonstrable, involuntary urine loss that is socially and or hygienically unacceptable to the patient or her caregivers, fine? So these words are actually self-explanatory, but why we are laying a little emphasis on it is because in the year 2000, the International Continence Society said that urinary incontinence is a complaint of any involuntary leakage of urine. So when we say complaint, what does it become? It is a symptom, fine? It is a symptom with which the patient comes to us. However, the same society in 2015 has said that urinary incontinence is defined as urine leakage seen during examination. So when we say seen, what does it become? It becomes a sign, fine? So this is again a viva question, which the moment you start talking of urinary incontinence, the examiner may just stump you by saying that, okay, tell me, is it a symptom or a sign? So say that, sir or madam, it is both symptom as well as sign. And there is one more to it, which I'll tell you later, fine? Now this leakage could be urethral or extraurethral, fine? You're either coming from the urethra or extraurethral. Now again, why this is in red is because one of the books, it mentions that when there is extraurethral leakage of urine, it is actually not incontinence, but the vast majority of authorities do not believe so. Fine. So in extraurethral incontinence, now because you are not in front of me, otherwise I would have asked you these questions and one of you would have answered it, but I am sure you will, in your mind or wherever you are sitting, you'll keep answering the questions so that you know that your answers are correct. So extraurethral incontinence is also known as total incontinence. And this extraurethral incontinence we are going to encounter when we see a patient of urinary leakage through a fistula. Now, when you have answered this leakage from a fistula, this is 60% marks. For 75% marks, we will ask you any other disease entity where you can get extraurethral incontinence, so that extraurethral incontinence can also be from a ectopic ureter. Sometimes what can happen is that there is an ectopic ureter which is opening into the vagina. Not common, but yes, if you are asked where else apart from fistula do you get extraurethral incontinence or total incontinence, so this is the answer. Now this is a disease of huge magnitude, fine, huge magnitude. Now the common diseases which we keep talking day in and day out, hypertension, diabetes and so on and so forth, what has been found in various studies is that it is urinary incontinence which is one of the commonest ailment amongst women. Now still some time back, whenever we used to talk about urinary incontinence, we would say that we do not have Indian data. Now, a study has been done in our institute itself, and it has been done by a nursing staff. Her name is Jyoti. Now, what she did was that to find the incidence of urinary incontinence in women, she went with an interview questionnaire to medical, surgical, eye and ENT OPD, not to gynae OPD. And the women who had come there for various other ailments, she asked them about urinary incontinence. And we found that actually this large figure is correct. Now, what is surprising is that none of these women were actually reporting to the doctor for treatment of urinary incontinence. Now, how would you remember these statistics? Very easy to remember that more than 30 years, 30% women. Fine, it is 35%, but even if you remember 30%, it is fine. So 30% women more than 30 years are affected. 60% women in the elderly age group. So what do you remember? 30% more than 30 years and 60% more than 60 years. Easy to remember, I think. And it also tells you that how common it is. As women start aging, that 60% women, mean more than half of women are suffering from some kind of urinary incontinence. But the surprising part is that 80% of these women, when they were interviewed, they find that it is a normal part of aging. Women talk to each other, their neighbor, sister, mother. They tell them, hota hai. This happens. This happens to me also. It happens to my friend also. So it is happening to you also. And they just do not take treatment. Fine. If you see various studies, now this incidence, you will find there is a wide variation. So do not get confused. The reason for this is that various people have used different research methodologies. They have used different definitions, and there are different population characteristics on which these studies have been carried out. The last and very important, again in red, what I just told you in the previous slide is the patient's attitude. They are suffering, but they don't report. So you don't come to know that how much is the problem. Now look at this figure that, a study was carried out in college athletes. Now college athletes, women are supposed to be fit. They are young women. And when they were interviewed, it was found that 27% of the college athletes had experienced some degree of incontinence sometime or the other. So that is why it is not only from exam point of view, even when you soon become consultants and go out to practice, you will find that if you sort of dig in a little deeper, you will find that there are so many other women who are suffering from this. And once you start offering them treatment, more and more patients will come to you. I'll tell you a little story. When I take my talks, I like to tell stories. Fine. Stories because they help us remember. About 15 years back, when I was relatively junior in my specialty, we started a procedure called TOT in our hospital. That is the transobturator tape, what we will be talking to you. So we treated a few patients. So it was a new kind of modality. And then we found that in the subsequent months, we started getting lots of patients. And one important category of these patients was our nursing staff, the sister who used to work in our ward, she came to the OPD because she was taking the ward rounds, and she says that, sir, I am also having this problem. I had my last delivery 15 years back. Since then, I am having a problem. I did not know where to get it treated. Now I see in the ward rounds, you people are doing some new surgery. So can I get treated? Not only that, we got ladies who were doctors and wives of doctors who started coming to us. So what I'm trying to tell you is that this is a problem which sort of remains hidden somewhere. Fine. And again, a little bit of those statistics, and probably the last slide on statistics, that 50% women of urinary incontinence are slightly bothered, 33% are moderately, and rest are severely bothered by this problem. And a lot of them take a lot of time to go and report to the doctor. One factor why there is underreporting of this problem, which the patients have told us, is that they sometimes do not know that who is the doctor who is going to treat them, whether it is the gynecologist, whether it is the neurosurgeon, whether it is a general surgeon, or which OPD should they go to. Fine. So we have to also create awareness. Fine. Now, after those statistics, and before we go to incontinence, let us see that what keeps a woman continent. Fine. I always like to tell my students that, this entire world of medicine, whatever we may practice, it rests on 3 pillars. And what are those 3 pillars? These are 3 very sound pillars, that of anatomy, physiology, and biochemistry. Fine. So let us see a little bit about anatomy and physiology, which will tell us that what keeps a woman continent, and then we will go to incontinence. So in this mechanism of continence, the first thing is innervation, and second is anatomy. So 2 broad things. Now let us dig in a little deeper. What we want from the bladder as doctors is that the bladder should be stable and compliant. Now let us understand what is the meaning of this stable and compliant. What I want from the bladder to keep a woman continent is that when the bladder is filling, if this is the detrusor muscle of the bladder, so there should be no twitching in this bladder. Fine. There should be no twitching over here. It should remain absolutely quiet. It should just quietly keep getting distended. And if this is the sphincter, this sphincter should remain tightly closed. In the filling phase, the sphincter should not open, and the bladder should, like a good child, obey the command and keep distending quietly. Also the reverse, that when the individual has to pass urine, this bladder should contract nicely and strongly, and the sphincter should open. Fine. So in between the filling phase, if the bladder is not stable, there will be a little incontinence, which I will be explaining to you. Apart from this, what we want is a intact neuro-urological axis. So there are 2 parts, neuro and uro. Fine. So for neuro, we should know a little bit of blood supply. I will not confuse you with too many details in this nerve supply. Sorry, I think I said blood supply. So it is the nerve supply. Fine. Now, the nerve supply, we have to understand that there is a sympathetic nerve supply from L1, L2, parasympathetic from S2, 3, 4, and the somatic nervous system supply, which comes to the external urethral sphincter, the pelvic floor, and the anal sphincter. Is that correct? So sympathetic, parasympathetic, and the somatic. Now, what does this sympathetic do? What it does is that it comes from the hypogastric nerves. It acts on the alpha adrenergic receptors, which are located in the bladder neck and urethra, and their stimulation increases the closer pressure. The beta adrenergic receptors, which are located in the bladder, their stimulation decreases the bladder tone. So now if you have understood this, what the sympathetic system is trying to do is that it is trying to keep the bladder distended and the sphincter closed. Fine. The bladder distended and sphincter closed. That is, it is helping in storage of urine, right? Okay. Let us go on to the next then. The parasympathetic system, which comes from the pelvic nerves, and their stimulation, they stimulate the muscarinic receptors in the detrusor. So when the detrusor will now contract, it will result in bladder empty. Fine. So sympathetic and parasympathetic, they are doing the opposite things. And the pudendal nerves, as I told you, is the somatic nerve supply, which result in stimulation of, apart from the pelvic floor, etc., the stimulation of nicotinic receptors in the bladder neck. Okay. So sympathetic is helping in storage, whereas parasympathetic is helping in voiding of urine. So again, now this is that tips and tricks that I told you, that even though I am sure all of you understood, nothing very difficult. How do you remember in all the tension of the exam that which one helps in storage, which one helps in voiding? So remember this line, that the sympathetic is sympathetic to the patient, right? It sympathizes with the patient. It does not let the patient become incontinent. It helps in storage of urine. It keeps the sphincter closed and the bladder distended. Okay, if that is clear, so we go on to the next thing, and that is all this sympathetic, parasympathetic is happening at a lower level, but all this is also there in a baby who's just been born, but that little baby doesn't have a control over the bladder, right? So this control comes with bladder training, which is a CNS control, fine, and this is like a on-off switch. What do we mean by on-off switch? That when it helps in that same mechanism, that when the bladder is distending, it keeps the sphincter closed, and when the individual has a facility of a toilet available, it gives the other signal, so that now the bladder starts getting contracted and the sphincter starts opening up. So it helps that it maintain that circuit that maintains the reciprocal relationship. Now, after having spoken about the neuro-urological axis, the second thing is the anatomy. So in anatomy, the continence depends on two factors. One is the extrinsic factor and second is the intrinsic factor. Now, what are these extrinsic factors? The extrinsic factors are the anatomical intra-abdominal position of bladder, neck, and proximal urethra. I will just show you a beautiful diagram and which will make it very clear to you. And the second thing is a hammock-like support offered by the pelvic floor. Hammock is that, swing kind of thing in which an individual can lie between two trees and have a nice time. So a hammock is shaped something like this, right? So that is how this pelvic floor offers it a support. I will be just showing you a diagram which will make all this very clear. And this hammock-like support is offered by the pubo-urethral ligament and urethro-pelvic ligament. Fine, I'll just show you what I'm saying. The posterior vaginal wall offers an indirect support. All of you know that the posterior vaginal wall is like this, and this is the anterior vaginal wall, and in front of the anterior vaginal wall is the bladder and the urethra. So posterior vaginal wall is offering a indirect support. This is what I was telling you. Now, for the time being, I just want you to focus on the left side of the slide where the word normal is written. Don't see on the right, fine? Now, if you see this beautiful picture, what you find is this yellow colored thing is the bladder. Below that, the tube that you see in pink or red color is the urethra. And this oval in between is the striated urethral sphincter. And this curvilinear thing below, C-shaped thing that you see is the pelvic floor. So in a woman who's absolutely fine, there is nothing wrong with her anatomy. So what happens is that whenever there is an increase in intra-abdominal pressure, this pressure is transmitted to the bladder, and because this sphincter is part of the pelvic floor, and above that, the pressure also is transmitted to the sphincter and to the proximal part of the urethra. Now, all of us are students of biology, but we can understand this much of physics, that if equal pressure is being applied on the bladder as well as on the sphincter, the two of them neutralize each other, So there is no incontinence. So this is part of that anatomy description which says that why a woman remains continent, fine? Let us go on to the next slide. And this is those supports that I was telling you, that is a hammock-like support. Now, if I take this pelvis over here, now all of you are familiar with this, and let us say, for purpose of demonstration, this is the bladder, This is the bladder. So this bladder would be here somewhere. Now, what will happen is that there will be two ligaments which will be supporting it. Anteriorly and laterally will be the two pubo-urethral ligaments going from the pubis to the urethra. Pubis to the urethra. Anteriorly, like a V, they will be lifting it up. Fine. And posterior to this, posterior to the breast, there would be a hammock like this. Fine. So there would be a hammock like this. So which will be made by the uretropelvic ligaments. Now these ligaments are actually condensations of fascia over there, but extremely important in keeping a woman continent. And finally, towards the end of the class, when we reach the treatment modalities, you will see that why they are extremely important to know, because they help us in treating the patient. So many of the recent treatments that we offer are based on this anatomy, and that is why it is important to know. Now, apart from these supports that we talked of, there are other things which help keep a woman continent is intrinsic factors like the striated and smooth muscles of the urethral wall, the submucosal venous plexus, and epithelial coaptation of the folds of urethra. Now, these are the things which we should know, because when a woman becomes old, we said, 30% less than 30 years and 60% less than more than 60 years. So, why is it rising in postmenopausal women, elderly women? Because estrogen has gone away. And when estrogen has gone away, it is the submucosal venous plexus, the epithelial coaptation of the urethra, the strength of the muscles, these become weak, because now the support to the collagen is not that good. The blood supply is not that good. And that is why postmenopausal women are likely to have more chances of urinary incontinence. Fine. So if you've understood this, just a few values which you should remember, and the one which I want you to really remember have been written in red. So on an average, an adult would pass urine 7 to 8 times, and up to 1 time in the night is okay. Fine. This is an average, and we should know because it will help us evaluate the patients. Residual urine, that is the amount of urine which will be left after an individual has voided urine, should be less than 50 ml. And the individual should get the first desire to void when there is about 250 ml of urine in the bladder. Now, these things you should keep it at the back of your mind, because when we sort of go further, these will come handy. Okay. Now, having talked about the definition, the clinical importance, the incidence, and the anatomy of physiology of urinary incontinence, let us go to the types of incontinence. Now, I'm sure you must have heard some of these names, so we will just list them out. The first one is stress urinary incontinence, which is the topic of our today. The second one, and which we also should know to diagnose before we can diagnose stress incontinence, is urge incontinence. And the third one is mixture of the two. Now, my dear students, it is these 3 types of incontinence, stress, urge, and mixed, which constitute 98% of all types of incontinence. So what are the other 2? One is overflow incontinence. This overflow incontinence, nowadays, the people, what they are saying is that it is actually a type of urge incontinence, but I wouldn't subscribe to that view. Overflow incontinence, all of you who've been worked in labor wards, etc., you must have seen that once in a while there is a patient who after delivery does not pass urine, there is retention of urine, and then you sort of, she has some pain and you have to go and catheterize the bladder. You leave that catheter in situ and she becomes okay after some time. Now, this particular patient, it is possible that when you ask her that have you passed urine, she may tell you that yes, I have passed urine. In fact, every 15 minutes I'm going to the toilet to pass urine and I'm passing a little bit of urine. So then how is this urine getting collected? It is getting collected because it is like a bucket which is full to its capacity. Any more urine which is coming in that, it is actually getting leaked out every 15 minutes. Fine. There are various factors which can cause this overflow incontinence, but for the time being, we will not go there. And the last one is total incontinence, which I have already told you, that is from the fistula. Okay. Now, because the first 2 that I told you, the stress and urge, are most important and most common, Let us define them. What is stress incontinence? So stress incontinence is, as the name suggests, that whenever there is a stress in the form of an activity which increases the intra-abdominal pressure, the patient leaks a little amount of urine. So activity like coughing, laughing, sneezing, or in patients who are badly off, even if she is traveling in a car and there's a big speed breaker, so she leaks a little amount of urine. So that is what is stress incontinence. The typical history which this patient will give you is that any of these activities that I do, I leak a little amount of urine. The second one is urge incontinence. And in urge incontinence, what happens is that there is involuntary leakage of urine resulting from a hyperactive or a irritable bladder. I had shown you this red colored model of a bladder. So what I was telling you is that this should remain stable and compliant, like a good child should behave. Sometimes what happens is that starts getting irritated. The bladder is actually filling, but it is twitching. Now when this is twitching, there is some amount of leakage of urine. What is the typical history which this patient gives you? The history which this patient gives you is that, doctor, whenever I have an urge to pass urine, I have to run to the toilet. I can't wait. And so many times what happens is that before I can reach the toilet, I just pass urine. Now this lady, when she passes urine, what will happen is that she will empty her complete bladder. She will wet all her clothes. So that are two very distinct histories which these patients will give us, and it is important for us. And the third one is a mixture of the two. Now, this part I have already covered, that stress urinary incontinence can be a symptom and a sign. And the last thing is that it can also be a urodynamic observation. This is what I told you in the beginning, that you learned that urinary incontinence could be a symptom, it could be a sign. Third is that it could also be a diagnosis. So all three things, fine. And this is how we like to tease you a little bit in your Viva, that, okay, tell me what is a symptom, sign, diagnosis. So please be very confident and say it is all three, fine. So that is what is stress urinary incontinence. And activities, this I have already told you, that what are the activities which are predisposing to development of stress urinary incontinence. Now what happens? Why in some women, what goes wrong with these women that they develop stress incontinence? So there are two problems which can happen. One is that there could be hypermobility of the urethra. So what did I tell you? That, if this, I had shown you that blue color diagram and I showed you a pelvic floor. So the sphincter was here somewhere at the junction of the two. Now if this goes down, she develops stress urinary incontinence. Again, I'll show you a picture and you will understand it better. And the second problem that could happen is intrinsic sphincter deficiency. So two different things. One is that the urethra has actually become hypermobile. It has descended down. Second is that it is in its normal place. However, the sphincter which was supposed to be keeping it closed is now not competent. It has become incompetent. It is giving way. So it is intrinsic sphincter deficiency. All of you should remember these two things, that what are the pathophysiology of stress incontinence. Now, you've seen this picture a while back. Now you look at the right side of the picture. So you've learned the normal. Now look at the right side, where on the top it is written SUI. So in this lady, what has happened is, just focus over here, all the pelvic floor. Compare these two. So here what has happened is that the pelvic floor has become thin. It has become atrophic. There is also a little descent here. Fine. This was nicely tight, but this has become loose and it has descended a little bit. Now when this descent has occurred, the sphincter has gone out of the purview of the abdominal wall, below the pelvic floor. So now what happens is that when there is an increase in intra-abdominal pressure, this pressure is transmitted to the bladder. However, because this part is not there now, which was there on the left, no pressure can be applied onto the sphincter. So pressure here is more now and less in this part. That is why whenever there is an increase in intra-abdominal pressure, what will happen? A little amount of these yellow colored description, what has been shown in the diagram, a little urine will leak out. So I hope all of you understood this concept of hypermobility of the urethra, right? The second is intrinsic sphincter deficiency. So in intrinsic sphincter deficiency, what is happening is whenever there is an advanced age, inadequate estrogen levels, previous vaginal surgery, neurological lesions, they lead to poor sphincter function. Easy to understand. Lack of normal intrinsic pressure in the urethra. Any increase in the intra-abdominal pressure will lead to urinary leakage. Fine? Okay. So now when we have understood all this and we are, armed with this knowledge of the definition, what is continence, what is incontinence, now let us all imagine that we are with a patient. Right? So you have a patient with you and you have to take history. History taking in a case of urinary incontinence, if you take a detailed history, we will be covering all that, you will reach almost the correct diagnosis in a vast majority of your patients. So history is extremely important. So now this is what your patients of SUI will come and tell you. She'll say that whenever I cough, laugh or sneeze, I leak a little amount of urine. Fine. This is what most of our patients will tell us. What should we know? We have to know about this associated history. This associated history is a history of prolapse. I'm sure all of you who are listening now, you understood that why prolapse is important, because there is descent, hypermobility of the urethra, we just now discussed. So when the anterior vaginal wall is descending, any structure which is above that is also likely to descend. Hematuria or dysuria, all of you know that hematuria or dysuria are symptoms of urinary tract infection. Now, what you should know is that when there is urinary tract infection, if you don't take care of it, if you do not give it the cognizance, this itself may be the cause of urinary incontinence. We will keep evaluating this lady for everything, mixed incontinence, stress incontinence, this, that. But actually what she has got is UTI. So all these patients, you have to ask for history of dysuria or hematuria. Then you have to ask history of urgency, frequency, and nocturia. Urgency, I told you that when she feels the urge to go to the toilet, she has to run to the toilet. You have to ask the patient, is this what happens with you? Yes or no? So now what you are doing is you are narrowing down your diagnosis, that whether I am dealing with urge incontinence or stress incontinence. Frequency, how frequently do you have incontinence and how frequently do you have to go to the toilet? Both the things. And nocturia, that do you have to repeatedly get up in the night to pass urine? Remember, we all learned about a while back that 0 to 1 times, either no word or 1 word in the night is okay, but anything more than that is not okay. COPD, why is COPD important? Chronic increase in intra-abdominal pressure, leading to, remember those big P's that you saw in that diagram, so increased pressure. Chronic constipation, increase intra-abdominal pressure. Okay. So this is the history that you can take. All of us can take this history, but sometimes what happens is that you may forget a few questions. So to help us all with that, there are questionnaires that are available. Now learned people have made these questionnaires, but because these questionnaires have become so elaborate and long, the doctor or the resident, you have to go to the labor ward, this, that, call from here, some professor is shouting at you, itna lamba questionnaire, fine, you don't have time to fill it up. So what you do is that actually it just keeps lying in the bag, you don't fill it up only. So what has been done is that life has been made a little simple. What is the simplicity? This is 3 IQ or just 3 incontinence questions. 3 IQ. Simple questions, all of us can do it. So what you have to ask the patient, the first question is that during the last 3 months, have you leaked urine? So what will she say? She'll say either yes or no. If she says no significant urinary incontinence, you can take it like that. If she says yes, obviously if a patient has come to you with incontinence, she'll say that. So proceed with the second question. So what you ask her is that during the last 3 months, have you leaked urine? And what she has to now tell you is that when did you have leakage? When you were performing some physical activity like laughing, coughing, sneezing, because that tells you that this is likely to be stress incontinence. Second question, that when you had the urge or feeling that you needed to empty your bladder but you could not get to the toilet fast enough, leading to urge incontinence, other direction. Fine. The third question, that without physical activity and without a sense of urgency, so neither A nor B, so you ask this, Now, if she says that this one is also correct, then we will have to evaluate this patient in a detail to find out that what is her problem. Now, what we have done is that we are left with one more question, and which will complete our sort of history taking, that during the last 3 months, have you leaked urine? And now you ask this patient to mark only one. Fine. And what is this one question? Same. When you were performing some physical activity like laughing, coughing, sneezing, or when you had the urge of feeling that you needed to empty your bladder and you could not get to the toilet fast enough. 2. Third, without physical activity and without a sense of urgency. Same. And last is about equally as often with physical activity as with a sense of urgency. Fine. So now I'm sure all of you understood that why this D is important, because when we saw that diagram in which we said 98%, there was one big group of mixed urinary incontinence. Fine. So this is that last group. And the question is C, patients who point to that C, these are those patients who fall in that 2% of the group where you have to look for the rare causes of urinary incontinence. Fine. Now, all this sounds very simple and good to do in a webinar or when a class is going on. So it is black or white, or there is a little gray. Practically, what can happen is that it may not be so easy. So what do? Now you are stuck. You are asking the patient, this happens. He says, yes. That happens. Yes. Sometimes she's language problem, old patient, not able to talk. So what do? So what you can do is that you can make something known as a voiding diary. Now in this making this voiding diary, you can involve the family members also. Fine. What she does is that she notes the time of oral intake and voided urine and any time of urine leakage or pad change. Fine. Easy to do. So you just give her this 3 pages of paper in which this is printed and just tell them to keep noting it. Now, for how long should they keep it? Now, this is a viva question. Now, when you have explained the complete voiding diary, then I will ask you that for how many days will you do it? So say I will do it for 3 days. Fine. Not because I am saying, because this is the standard recommendation. Fine. 3 days is good enough. So in this, now what we have to see is that whether the patient is having daytime leakage or nocturnal leakage. Now I will give you the answer, but I want all of you to start thinking that what will it be if it is a daytime leakage? What will it be if it is a nocturnal leakage? I can see some of you answering already. I mean, I can't see you, but I can imagine that you would have given those answers. What happens when there is a small fixed volume day and night frequency? So then what you have to think of is in terms of interstitial cystitis. Now I'm talking of the rare things. Fine. Also, what you have to remember, there are some people who are compulsive water drinkers. Fine. A lot of film actors come on TV, they keep saying, keep drinking water, keep drinking water, keep drinking water. Now, if this individual is drinking water till the time she goes to sleep, obviously she'll get in the night 2-3 times to void urine. Fine. But if you do not take history, you will start doing all kinds of investigation and land up nowhere. Fine. So that is why history is important. Okay. Now, normal number of voids is 8 per day. We have told you. Increased number of voids. Number of times the patient has gone to the toilet has increased. So you have to think in terms of urge incontinence, urinary tract infection, calculi, and interstitial cystitis. Okay. Calculi in the bladder. If the patient now says post-void dribbling, mark you, now these points that we are talking is not the black and white of urge and stress incontinence. These are the rarer groups. When there is a post-void dribbling, there could be a urethral diverticulum. Fine. So why this urethral diverticulum is not a total incontinence like in an ectopic ureter or a fistula? Okay, I'll give you 5 seconds to think that why in a urethral diverticulum she should not be leaking urine continuously, but only she should be dribbling a little amount of urine post-void. I'm sure a lot of you got the answer. The reason is that otherwise there is no urine in the urethra. Fine. The urethra remains closed. The two walls are close to each other. Only when urine passes through this urethra, that is the time this urethral diverticulum can lead to post-void dribbling. Okay. Now we have maintained this diary for 3 days, and she's come with her family. She's maintained the diary. So how do you analyze it? Now this is the analysis. So what is the analysis? That if the frequency with urgency is more, likely to be urge incontinence. It is also used to be called the overactive bladder. Walking to pass urine at night more than once, usually urinary incontinence, the urge incontinence. Seldom in stress incontinence. Why seldom in stress incontinence? Because when she is sleeping, there is no increase in intra-abdominal pressure. There is no laughing, coughing, sneezing. Right? Okay. Urgency history is strong in urge incontinence, but not so in stress incontinence. Ability to reach the toilet in time to following the urge to pass urine is absent in urge incontinence, present in stress urinary incontinence. So a woman who's got stress incontinence, she will not leak on the way to the toilet. A woman who's got urge incontinence will leak on the way to the toilet. Amount of urinary leakage, I told you when we were talking of those two definitions, that in urge incontinence, she will empty the complete bladder, whereas in stress incontinence, a little amount of urine is passed. Physical activity, yes, in stress incontinence, no in urge incontinence. So if you just take these 4 or 5 symptoms and add this at the 4th page at the end of her bladder diary, you will reach a working diagnosis. Fine. I'm sure all of you can do it. All of us can do it. Fine. Okay. Now, the next history. Fine. Now, imagine I told you that now we are imagining there's a patient sitting in front of us. So we've taken all this history and then we go to obstetric history. Now, I think we know that a vaginal delivery is likely to predispose to stress incontinence. Why? Because repeated vaginal deliveries, there are chances that the pelvic floor may become lax and the sphincter that we were talking of may descend down and she may have stress incontinence. So should we start doing cesarean for all of them? We will do cesarean for all women, so nobody will get stress incontinence, right or wrong? Okay. Now, obviously, you can't give me answer in this forum, but whenever we have a class physically, you'll tell me. And I know you must have got the answer also. So the odds ratio is 1.7 in favor of cesarean. What it means is that the women who have cesarean have less chances of developing a stress incontinence later on in life. But there is a very important but, okay? And that important but is that this apparent protection that it provides, a cesarean delivery versus a vaginal delivery, is short term. It dissipates with age and additional deliveries and is not present in older women. So I'll explain this statement to you. What it means is that if in young age, when a woman is having her children, if you do cesarean as compared to a vaginal delivery, what you will find is that in the initial few years after that, there are less chances of her developing a stress incontinence as compared to a woman who's had a vaginal delivery. But by the time these women, these are all statistical analysis, fine? That these women, they reach their 50s and 60s and postmenopausal status, this apparent difference which was there in between them will get neutralized. So what is the lesson for us? The lesson for us is that there may be other indications for cesarean, but it is not correct to do a cesarean to prevent stress urinary incontinence. What about birth weight? Yes. So the data says that women who have had children more than 4 kgs birth weight delivered vaginally are more likely to develop stress urinary incontinence. Fine. Okay. We are continuing with history, mind you. Smoking, understood. Chronic cough, increased intra-abdominal pressure. Alcohol, multiple problems. Fine. That it leads to sedation, confusion, and diuresis. It does, again, in short term, does a few good things also apparently, but certainly not. Fine. So don't go for that. Yeah. So people feel that it is doing something good, but it is actually not. It is creating a lot of problem. Okay. So diabetes. Now in diabetes, what happens is that there is diuresis. What are the classical symptoms of diabetes? Polyuria, polydipsia, and polyphagia. So when there is diuresis, patient has to go to the toilet more. She has to wake up more at night. And because she is a diabetic, there are more chances of developing a urinary tract infection. Then neurological disorders. Fine. You remember we talked of that central nervous system control. There's one bandmaster sitting on top who controls this on-off switch. So cerebral cortex to the peripheral nervous system. Family history. Now this can again be a catch question in a viva. That is there any relevance of family history? Yes, it has been documented that women who have had history of stress incontinence in their mother, sisters and aunts are more likely to develop stress urinary incontinence. Drug intake. If you forget asking history of drugs, you may land up in problem, because you will evaluate her, you will treat her, probably operate her also, but actually the cause is that she is taking some medicine for some other disorder which is causing her problem. And what are these drugs? Sedatives like benzodiazepines, alpha blockers like prazosin, because they decrease the urethral pressure. Now again, that P, physics that I told you, pressure on the bladder, pressure on the urethra, they have to cancel out each other. Calcium channel blockers, they lead to reduced bladder smooth muscle contractility and patient has difficulty in voiding. Nocturia. And ACE inhibitors lead to chronic cough leading to increased chances of SUI. Now, all of us, since our first MBBS, since we studied anatomy, we are fond of reading mnemonics. Even I am very fond of mnemonics, and this is a mnemonic which may help you. So what does it say? In red, from top to bottom, if you read, it says diapers. Fine, we are talking of urinary incontinence. So diapers is relevant. D for dementia, infection, atrophic vaginitis, psychological, pharmacological, endocrine, restricted mobility, which does not let the patient reach the toilet in time, and stool infection. All right. So now what we have done is, after having given our definitions, anatomy, physiology, continence, incontinence, pathophysiology, we have taken history. This patient is sitting in front of us and we started examining her. Now, most of you, when you start presenting your case to the exam, this is how you will say: general examination, my patient is averagely built, pulse, BP, so on, no pyeloelectrus, lungs and CVS, fine. Now, in his case of stress incontinence, this is not good enough, because we have left out one or two very important things. And what is that very important thing? That very important thing is the weight. You have to see weight. When we talked of factors causing incontinence, we said obesity, one of them. Fine. Increased weight from top, increased pressure, so increased chances of stress incontinence. Now, because weight is apparently something very basic, I thought I will tell you two more things over here. Fine. So if a patient is obese, she has more chances of developing stress incontinence. Now, apart from weight, what are those other two very important things? What happens in a viva, I'll tell you. The examiner, no examiner comes from home with a fixed set of questions. Whatever you speak, we ask you some questions on that only. So when you start presenting that my patient 50-year-old, so I will ask you that, okay, what is the correlation of age with urinary incontinence and why? So this is what almost all the students will be able to tell, that this is the correlation of age with urinary incontinence, that when she becomes postmenopausal, there is reduced estrogen, effect on pelvic muscles, bladder trigone, reduced vascularity, reduced urethral mucosal seal, so incontinence. Fine. This is the answer for about 55% marks. Fine. But I want all of you to score 75%. So what is that additional 20% marks? With age, what happens is that there is involuntary detrusor contractions increase, leading to chance of urge incontinence. The total bladder capacity and ability to postpone voiding decreases with age. Now the bladder cannot distend so much. The urinary flow reduces. Now neither the bladder can distend so much, nor can it contract so efficiently. There is more. The second common factor that I thought I'll combine with weight is, one was age and second is race. So what has been found is that SUI is more common in whites, whereas urge incontinence in the white Americans. Now coming to the controversial question. What is this controversial question? That if a patient has had a previous surgery, let us say a patient has had a hysterectomy. So do the chances of her developing a stress incontinence increase? Well, this is what people used to say, but what is now the latest finding which is coming from various studies. In fact, it is there in the textbook. It is there in the textbook, so you can quote it, that actually doing a hysterectomy does not significantly increase the chances of a woman developing stress incontinence. There was a phase which had come when people said that let us start doing subtotal hysterectomies to keep maintaining the support. Let us leave the cervix behind, just remove the uterus. So not required to do, fine, because hysterectomy as per the standard textbook does not increase the chances of developing a urinary incontinence. Okay, so having done the general examination and learned a couple of things on this side, let us now start doing a systemic examination. So my dear friends, do not straight go to the gynae examination, fine. Start with neurological examination. What you have to see is the mental status, mobility, whether the individual can walk, what is the gait. Then you have to do an abdominal examination. Now, why should you do an abdominal examination? Because you want to see that if there are any lumps or hernia over there. Imagine if this is the bladder and on top of that a 30-week size fibroid is sitting. It will keep pressing on this bladder and make it push down, leading the patient to develop stress incontinence. So if there's a big lump is there, if I do the abdominal examination, I will pick it up. Okay. Next is a perineal examination. Fine. So first thing that you should see is that is the vulva well estrogenized, because there is an important role of estrogen, age, etc. We have just studied. Fine. Now, if you see what I was telling you in the beginning, if you know the anatomy, physiology, pathophysiology, it becomes so easy to understand and explain that why do I want to see if the vulva is well estrogenized or not. Then you have to see that whether SUI is demonstrable or not. Now, in this very important two things that I want to tell you, that in gynae practice, we examine almost all our patients on empty bladder. In fact, that Didi or Moshi who shows you the patients, what she will do is that before and only she tells all the patient that you first go to the toilet, pass urine and then come. When you want to examine a patient of stress incontinence, you have to see her on a full bladder, not an empty bladder, full bladder. Fine. So patient is to be examined on full bladder, and you can make her lie down in a dorsal position. Now, this is one situation where not only the patient's position, even the doctor's position is important. Fine. Why? Because where should you stand? You should stand on side of the patient, not in front of the patient like you examine her for prolapse. Why? And what do you do when you stand on this side? You separate the labia and ask her to cough. And if she's got stress incontinence, what you will find is that one spurt of urine comes out. Fine. Now, why? I hope all of you have understood why is the position of doctor important. Because if you are standing in front of the patient and ask her to cough, what you will get is a spurt of urine on the forehead. Remember, a lot of things what your professors tell you is from their own experience, right? So I am also a professor, and this particular point I am telling you from my own experience, that if you sit in front of the patient on the stool and ask her to cough, you will get a nice spurt of urine on your forehead. Fine. So you can imagine that it will not be a very pleasant situation. So stand on this side, ask the patient to cough. And after that, what you do is, if you've seen that patient when she coughs, there was a spurt of urine, you just take two fingers like this and take it on the side of the urethra like this. I hope you can see. I'll take some other colored tube. So yeah, I think this is what you can see. So this is a Foley's catheter, but for the time being, consider this to be the urethra. Fine. Yeah, this is a better contrast. So when you are elevating it, you should not press this urethra. Your finger should be on the other two sides of the urethra in a pelvis like this. So this is where the urethra would be coming, and you will put your two fingers and elevate the walls of vagina. So what is this is called is a cough stress test, that asks the patient to cough, and if she leaks urine, she's got stress incontinence. And then you do this Bonney's test, that is with two fingers you lift it up and now ask her to cough again. So now when she coughs, there will be no spurt of urine. Why? What have you done by lifting it up? That same pathophysiology that we studied, that now this anterior wall of vagina along with the sphincter which had descended down, with your finger you have temporarily taken it up. And it also tells you that any surgery that you are going to perform, when you are going to lift this part of the anatomy up, she is likely to respond to that. Fine. Before we go ahead, sometimes what will happen is that when you make the patient do this cuffing, you will not find any spurt of urine. So then what do? There are 2-3 possibilities. One possibility is that her bladder is not full. She has come from somewhere far away. You told her to fill her bladder. She says, I'll have to wait for 2 hours. She says, no, my bladder is full. The patient is only not telling you. She comes and lie down on the table. So her bladder is not full. Ensure that the bladder is full. Even then, if it is not happening, just help this patient from lying down to a sitting position on the gynae table itself. She can just squat. So you put her in a squatting position like a Indian style toilet. And then you separate the labia and ask her to cuff. Because now what is happening is that this bladder along with her torso has come up. So there, the actual pressure which was being felt on the bladder is being felt in this position. Sometimes you can even make them stand and do it. But generally that is not required. Even if you just make them squat on the gynae table, you can see the spurt of urine. Okay. The next thing is that you have to continue with this pelvic examination, and you've seen that whether the estrogenization of vulva, SUI and Bonney's test. Further to that, what you will see is the size of the uterus. You do a PV examination and look for the size of the uterus, because if there is a big fibroid over there, there is a mass over there, that could be the cause of an incontinence. And on the other side, you have to look for UV descent. Very important 2 things in UV descent, and this is for the final year students, that let us say you have a patient who is complaining of SUI. She is also complaining of mass descending PV. You are examining her on the gynae table. The prolapse is out. You are asking her to cuff. She has got a full bladder, but still the stress urinary incontinence is not demonstrable. And what is the reason for that? The reason for that is that now the relationship between the bladder and the urethra has got inverted. Why? Because this is the place where the prolapse started happening. So a urethra which was supposed to be pointing out like this has actually become ulta along with the prolapse. Fine. And because of this kink in this urethra, I hope all of you are able to understand what I'm trying to say, that the anterior vaginal wall has prolapsed. So if this is the cervix, the urethra will be here somewhere and the bladder would be up. So there is a kink over here. So what you are supposed to do is that reduce this prolapse completely, and then ask that Mataji who is there with prolapse, after reducing the prolapse with an instrument, that now you cuff. And when she cuffs now, because temporarily you have removed that kink in the urethra, between the urethra and the bladder, now she will manifest with stress urinary incontinence. Fine. This particular entity is also known as occult incontinence. And why it is very important for us to know is that if you do not spend these 5-10 minutes time with this patient in the OPD to make sure that she has got stress incontinence, you will go and treat her uterovaginal prolapse. And because after your surgery, you have sort of reposed the anterior vaginal wall in its normal anatomical position, and now that kink is gone, 1 month after surgery, she will come back to you that my prolapse is okay, but now I have got stress incontinence. And then you will realize that we missed something when we were actually examining her for prolapse. Okay. Now, having discussed that, the other things which we are supposed to do in a pelvic examination is meatal examination, any caruncles, etc. over there, and see for the strength of the levator muscles. Then we are supposed to look for anal sphincter function, and you all know that beautiful word known as anal wink. Fine, you take a cotton swab and just stroke it in the perianal area, and the anal sphincter contracts. Having done this, there is another popular test and a question in the exam, that what is Q-tip test. So let us discuss this Q-tip test, how it is done and how you interpret it. So please focus over here. Fine. This is a schematic diagram. This is the pubic symphysis, this bone over here, this one. Behind that is the bladder. So this red colored thing is the bladder. Fine. And that is what you are seeing on the diagram. This opening is the urethra. Fine. In between that urethra, if you see a cotton swab kind of thing over there. Fine. Now what you do is that to do this Q-tip test, the patient has to be bladder full. You either take a swab stick, which you use for culture, or you take a sterile earbud, lubricate it, and insert it at the level of the uretrovesical junction. Fine. And now ask the patient to cuff or do a Valsalva maneuver. Now when she is doing this Valsalva maneuver, this cotton tip is inside, but the stick part is visible to you. Okay. So if she's got hypermobility over here, you will find that this stick is going up. It will move up in a hypermobile urethra. Whereas if it is not hypermobile, it will not go too much up. And how much is this too much? This angle is 30 degrees. That if this deflection of this stick is more than 30 degrees, it is hypermobility of the urethra. Whereas if it is less than that, the hypermobility of the urethra is not there. Now, just a while back, I said that this Q-tip test, we do not do it nowadays. Why we do not do it nowadays is that what they are saying is that in almost all our patients of stress incontinence, there is a combination of both the factors, hypermobility of the urethra as well as intrinsic sphincter deficiency. So if both the things are there and we have to treat it only, this Q-tip test does not help us in coming to any diagnosis. However, because if we have to prepare for an exam, we should be absolutely sure that how it is done. This I have already told you about the occult or the latent SUI. Fine. Now there may be some patient, you've tried all this, made her squat, this, that, you cough, bladder is full, thing is not happening. Why it is not happening? Probably she is in an unfamiliar surrounding. So what you do is that tell her to do a pad test. And this pad test is a semi-objective way in the sense that she is supposed to wear pre-weighed pads for a fixed amount of duration, which could either be 1 to 2 hours or for 24 to 72 hours, and do her usual activities, whatever she does. Fine. If she is doing a long-term test, if she is doing a short-term test, you tell her to do some exercise like climbing stairs, moving up, down, or she can do some skipping if it is possible. Otherwise, climbing stairs, it just helps. Fine. And it is not uncomfortable for the patient. And once she has used this pad, you call her back, you weigh these pads again. And if the weight of the pad has gone up and it looks wet to you, you know that she has leaked some amount of urine. The problem with pad test is that again, a little cumbersome to do. And second is that there is lack of standardization. Nonetheless, it is a part of our armamentarium and we should know it. Coming to the investigations. Now, what investigations do? You examine the patient. She has got stress urinary incontinence. Two things which we must rule out in all these patients is urinary tract infection and diabetes. And I have already told you why. Next is a simple investigation known as ultrasonography. Now, when you tell me in the exam ultrasonography, I will tell you why do you want to do ultrasound. And this is what you will tell me, that I want to rule out any uterine fibroid, any mass in the pelvis, which is leading to her stress incontinence. Again, that answer is 55% marks. For 70% marks, you have to say that I will also use the ultrasound to see post-void urine, because we are evaluating the patient. As of now, we do not know whether it is stress incontinence or not. We are just narrowing down our choices. So this is also what you have to see. Because post-void urine increase leads to recurrent infections. Urine could be caused by urethral obstruction or because of neurological problems. Okay. So these basic investigations we have done, and now we come to the important part, and a word which sounds very familiar, very important, very often discussed, can come as a short note in the exam, and that is urodynamic investigations. So what is this business of urodynamic investigations? Urodynamic investigations are anything which provides an objective evidence about lower urinary tract infection. Okay? It is an objective measurement of bladder function. And what is important is that all our patients do not need to undergo urodynamic investigations. Fine? Do not, repeat, do not. Fine? So it is not an investigation which is to be ordered for everyone, like a urinary culture or a screening for diabetes. Why? Because they are time consuming, they are expensive, they are invasive, and lastly, but very importantly, do not change the course of things. In the beginning, we had said that if we take a good history, we can reach very close to the diagnosis. So it does not change our outcome. That is why we do not do it for all. So when do we do it? I will just tell you. Fine. There is a wide variety of urodynamic investigations, and I will just list out the names of a few to you. I will not take you too deep into urodynamic investigations for two reasons. One is we do not do it very frequently, and second is that when you have to do those very complex urodynamic investigations, you will take the help of a urosurgeon colleague. Fine. But two things we should know. One is the simple cystometrics. Now, what is this simple cystometrics? Let us rub this. Yeah, let us talk about this. So, in simple cystometrics, you do not need anybody's help. By the way, even a bladder diary can be a urodynamic investigation. Why? Because, just let us go back. And what did we say? Urodynamic investigations, it is anything that provides us objective evidence about lower urinary tract functions. Fine. So, even a bladder diary is a urodynamic investigation. Okay. Okay. We are talking of this simple cystometrics. So in simple cystometrics, I can do it in a gynae OPD. You can also do it, no problem. So what you do is when the patient comes to you, you take a simple Foley's catheter, put it into the bladder, and drain the urine. Fine. Make this catheter self-retaining. After that, what you do is you take a syringe, okay, and you nicely attach this syringe to the Foley's catheter. Now what you can do is that keep taking a little amount of saline, fine, maybe 20 ml at a time, and start filling it. Okay. When you are filling it, in between what you do is that you take out this plunger and you look at the level. Fine. When the bladder is, you see any saline in this, you look at the bladder. This level should be absolutely stable. It should not be flickering. Fine. This you will see more towards the end when the bladder has become full with about 250 to 300 ml of saline. So you keep filling it. And you keep asking the patient when she gets the first urge to pass urine. Usually, she will get this urge at about 200 to 300 ml of saline. Now you have filled this. After that, what you can do is just hold it and observe this level of the meniscus of water. So where is this Foley's catheter connected? It is connected to this bladder. Fine. And if this bladder is unstable, if it is twitching, that twitching of this bladder would be transmitted to my level of the saline in this syringe, and I'll keep seeing it moving up and down. That will tell me that this is not a compliant bladder. She is likely to have urge incontinence. But I also want to see stress incontinence. So what I do is that now I deflate this bulb. I do not empty her bladder and take the Foley's catheter out. So now I know for sure that her bladder is full, and I ask her to strain, and I am likely to see the stress urinary incontinence. So this is not difficult. Again, this is not to be done for all patients, but when you have a difficulty, this simple cystometrics all of us can do. Then there is something known as multi-channel cystometrics. So I'm just giving you a little introduction into it. Now this is a diagram in your book. Do not get confused, very easy to understand, just a few terms which you need to listen for the next 2-3 minutes. So what we have done is they made a schematic diagram. This yellow thing is the bladder, and there is a bladder catheter. There is another catheter which has been put either in the vagina or in the rectum. We try to put this second catheter in the vagina unless the patient is having a big prolapse. Now both these catheters can measure pressures. The catheter in the vagina will measure the abdominal pressure, whereas the catheter in the bladder will measure the abdominal pressure as well as the pressure exerted by the detrusor. Understood? So pressure by the abdomen and pressure by the detrusor. So now look at this equation. So the pressure in the bladder, that is P vesicle, is equal to pressure in the abdomen plus pressure in the detrusor. Now pressure in the abdomen is also being transmitted to this vaginal catheter. So I know how much is the abdominal pressure. If I subtract abdominal pressure from the vesical pressure, I get the detrusor pressure. Simple. Again, like I said, we are biology students from class 11, 12 onward, but this much mathematics we all know. Okay, we have calculated this. What next? Now let us focus over here. So there are different scenarios which have been given vertically like this. So what you do is ask the patient to increase intra-abdominal pressure by cuffing or by doing a Valsalva. So there is an increase in intra-abdominal pressure. There is an increase in the vesical pressure also. But because there is no twitching of this, if there is the detrusor pressure is not generated, means both these pressures are equal and still there is leakage of urine, you have urge incontinence. Fine. Sorry, you have stress urinary incontinence, because though there is no increase in the detrusor pressure, you are demonstrating stress urinary incontinence. Whereas in the second one, if there is the increase in intra-abdominal pressure, equal increase in the bladder pressure also, no stress incontinence. Now look at over here. This is detrusor overactivity, that is urge incontinence, that there is no increase in the abdominal pressure, but where is the pressure being generated? In the bladder. So where did this pressure come from? This pressure came from this twitching of this bladder wall, and that is what led to detrusor overactivity and urge incontinence. Remember, there is a slight difference here between detrusor overactivity and urge incontinence. That if you are doing urodynamic investigation and you get this kind of a picture, whether or not incontinence is demonstrable, you will label this patient as detrusor overactivity. But if the incontinence is also there, then she becomes a urge urinary incontinence. Same thing, again in a different form of a chart, I will just try and show you that. Again, look at this vertically. Fine. So the patient is cuffing or doing a Valsalva maneuver. So there is an increase in the abdominal pressure. There is no net increase in the detrusor pressure. This is the normal response. In detrusor overactivity, that is when there is urge incontinence, there is no increase in intra-abdominal pressure. The pressure is being increased in the bladder, where it is coming only from detrusor activity and leak is visualized. So you have detrusor overactivity or urge incontinence. Whereas in stress incontinence that we were talking, when the patient coughs, there is an increase in abdominal pressure, there is an increase in vesical pressure also. They score out each other and leak is visualized. So this is stress urinary incontinence. There is no pressure being added by the detrusor, and in normal voiding, everything is fine. So if you understood this, fine. Otherwise, do not get too much confused, because we will usually not be doing it. However, if you get a question on this, at least this basics should be understood by all. If you have not understood, please post a question. At the end of the lecture, I will explain it again. Okay. Now, having talked of these urodynamic investigations, what we as gynecologists should know is that when to ask for these urodynamic investigations. Just about 10 minutes back, we said we do not do it for all patients. Then where do we do it? We do it, there is a long list, and this is an important question. When the history is not clear, when there is significant urge component along with stress incontinence, when there is history of urinary retention, when there is previous failed incontinence surgery, somebody has undergone a surgery, failed, now again come back with incontinence, so there is something wrong. When there is a continuous incontinence or leakage with minimal activity, fine, so there is something fishy. When there is history of pelvic radiation in patients of cancer, when there are elderly patients with multiple possible diagnoses, you do not know where you are headed for. When there is advanced diabetes, when there is history of nocturnal enuresis and other diagnoses are exhausted, and nulliparous women with stress incontinence, which is not a common finding, again, I will try to do the urodynamic investigations. There are certain physical findings which will tell me to how to do a urodynamic, that when to order a urodynamic investigation, and that is abnormal central nervous system, lower extremity, or pelvic floor neurological findings. Now, these are not common patients, fine? Uncommon patients, they've got neurological problem and she has come to you with SUI. So we have to do a detailed analysis and evaluate her completely. Known or suspected neurological disease as a cause or contributor to incontinence and high post-void residual volume. So there are 10 or 12 conditions when you will order a urodynamic investigation, even though you do not have to order it for all patients. Okay. So now what we have done is we started from definition, pathology, anatomy, pathophysiology, and history taking and examination. After that, we have done investigations, and now we have reached a diagnosis. So till now, what we were doing is we were trying to distinguish various types of incontinence, whether this is stress, whether this is urge, whether this is a mixture of the two, or whether it is one of those rare conditions, and so on. Now, for purpose of our discussion today, we have reached a diagnosis that my patient has got stress urinary incontinence. So how do I treat her? If she's got mild stress urinary incontinence, what I will offer is a conservative management. And what is that conservative management? There are so many things. The first one of them is Kegels. All of you would have heard this name. This is a set of exercises. And what the patient, who is a good patient? A woman who's young, who's probably had her delivery just now and has got stress urinary incontinence and mild cases of SUI. Remember, an elderly woman who comes to you with significant history of stress incontinence, which is easily demonstrable in the OPD, do not waste time on telling her to do Kegels, because she will come back to you. This is not going to cure her. Now, how it is done is very important. Fine. For this, there are 2 or 3 ways which I can tell you. One is that what is done in Kegels, that she is supposed to contract her pelvic floor muscles, and she has to do it in sets. Fine. She has to do it in sets. I will just explain what I mean. And you have to tell the patient that it will take a few months for her to respond or to see if this treatment is efficacious or not. When you are having a discussion in your Viva on stress incontinence and you say Kegels and you've scored 70% marks, this is the question that I will ask you. That stress incontinence, Kegels, when it helps in strengthening of the muscles, it makes the pelvic floor stronger. It helps in increasing stress incontinence. That is what is correct. But does it help in treating urge incontinence also? So the answer is yes. That if the women of urge incontinence do Kegels, it is known to help them also, because what happens is it is helping to, whenever she has an urge to pass urine, she contracts the muscles, and over a period of time, this reflex becomes stronger and stronger, and it can help her to a certain extent. I am not saying that Kegels is the only treatment for patients of urge incontinence, but for a specific exam question, that does Kegel help in urge incontinence? Answer is yes, and I have told you why. Now, Kegels, what you have to tell the patient to do is that she may be doing whatever activity at home. She have to contract her perineal muscles and keep it contracted, and then release it. Again, make it contracted, keep it like that, again release it, and keep doing that. She has to, once she contracts it, she has to learn to count 1, 2, 3, 4, 5, 6, 10, leave it. Again, she makes it contracted, again she does it. The problem with this is that some of our patients may not understand that what you exactly want them to do. So there are 2 ways of explaining it to them to help them identify the correct set of muscles. Otherwise, what can happen is that for 6 months, she can just keep contracting her either abdominal muscles or gluteal muscles, not the set of muscles which you want to make them to contract. So what you tell them is that what you do is that for 1 or 2 times when you go to the toilet to pass urine, midstream while you are passing urine, you just try to stop that flow of urine. So when she does that, she knows that what is this set of muscles which she is supposed to contract. Once she has understood this, after that she need not keep stopping this flow of urine all the time, but she has to replicate that action. The second is that we can teach her in the OPD. You make her lie down, you tell her to contract her muscles, you put your fingers in the vagina and tell her to squeeze. So once she does that squeezing action, she knows that, okay, this is the action which I am required to do. So that is what is Kegels, and it takes a few months' time for it to show its benefit. Then there are certain weights. So these weights are small weights which a woman can be told to put inside her vagina and try to hold it there. So what she's doing is that she's got a weight over there which she's trying that it should not fall out. So obviously when she's doing that, she's helping in contraction of her muscles. This weight training can be combined with Kegels also. So both are essentially doing the same thing at probably a different level. So these are all conservative management. Then there are certain incontinence rings which are available, which you can put in the vagina and can help these patients of stress incontinence by raising the urethral sphincter up. Apart from this, there are other conservative treatment modalities, some of which may actually not be so easily available, but they are there. And if you have to write a theory question, you please must write them. One is biofeedback and neuromuscular electrical stimulation. Now in biofeedback, what is done is that the same exercise which you made your patient do, the patient can get a feedback in the form of an audio or a video signal, fine, with the help of certain electrodes which are put over there. So she knows that yes, what she is doing is correct. The other importance of biofeedback is that like in an ICU patient, you give her the incentive spirometer with 3 colored balls. So she feels that, okay, yesterday I lifted 1 ball, now today I can lift 2 balls, the third day I can pull the third ball also up in that spirometer. Similarly, in biofeedback, she gives a feedback that, okay, I'm doing better now, I'm doing better now, fine. So it gives a positive or a negative feedback to the patient. In neuromuscular electrical stimulation, what happens is there are small electrodes which are put over there, and the physiotherapy people can help in this, and which can help in regeneration of nerves and strengthening of the muscles. Then what you can do is bladder training and timed wording. Fine. So in bladder training, tell her that she has to try to hold urine, make her muscles contract at the time when she feels that she is about to leak urine. And timed wording means every 2 hours, whether she has leakage of urine or not, she goes to the toilet to pass urine. So this reduces the chances of her leakage. And then weight loss, obesity is a big problem now. So tell the people to lose weight. More weight from top, more the bladder is pushed down, more chances of stress incontinence. Okay. So this was the conservative management, conventional, Kegels, weights, cones, incontinence dishes. And then some recent ones like biofeedback and neuromuscular electrical stimulation. Now let us come to the pharmacotherapy. Now as far as stress urinary incontinence is concerned, there is a very limited role of drugs. There are certain drugs which are available, which are selective serotonin receptor inhibitor, and duloxetine is one of the drugs which has been used, and people have said that 40 milligram OD can result in about 60% reduction in SUI and 80 mg in 64% reduction in SUI. But this data is limited. Fine. Pharmacotherapy is important in treatment of patients with urge incontinence. Fine. In patients of urge incontinence. So if it is not so important, then why are we talking of it? We are talking of duloxetine because there may be certain clinical scenarios where you may like to prescribe this. What are those clinical scenarios? Patient presently not willing for surgery. Patient presently unfit for surgery. Mild SUI, not very keen for operation. Patient you have operated and has come back, let us say after 1 year, saying that I am much better, my stress incontinence is much better, but I am not absolutely fine. I still have the problem sometime. So main part of your treatment has been surgery. A little problem is there, which you could put her on duloxetine. Now let us come to the management in cases of stress urinary incontinence, and that is generally surgical. So number of procedures described, anyone, any guesses? More than 150 surgeries have been described over the years. Fine. But we are not going to study history. We will keep our attention focused on what we are discussing today. So in these surgical methods, there is a long list, 150. I have categorized them into 4. One was the vaginal anterior colporrhaphy with Kelly's urethral plication. Like now, all old-timers like me, they have done this Kelly's urethral plication along with UV prolapse repair. So we used to put a few, if this was the bladder and this was the urethra that was prolapsing, so inferiorly on the anterior wall, we used to put a couple of sutures to try to lift this angle up. Nobody knew how much support it is giving. That was Kelly's plication. Then there is an important group of surgeries known as retropubic bladder neck suspensions, and in which one important surgery is Birch-Colpo suspension. There's another name that you see over there, MMK, that was Marshall-Marchetti-Krantz, not done now. Birch, definitely done. All of us will learn about it shortly. Then came another group of surgeries known as needle suspension procedures, in which STEMIs is one of them. There was others like Ras, Pereira and all that. Again, not performed now. The last one, and very important for us, is the mid-urethral slicks. And we will spend a lot of time discussing these 2 treatment modalities, that is retropubic bladder neck suspension procedures and the slicks. Okay, so now we know that there was urethral hypermobility and there was intrinsic sphincter deficiency, and we have got 2 important groups of surgeries that we said. One was retropubic bladder neck suspension and second is the sling procedures. So which operation for which patient? So retropubic bladder neck suspension is likely to benefit a patient who's got urethral hypermobility. Fine, you will just understand. I'll show you a video and in 1 minute you will understand. The sling procedures, very importantly, if you see, they are seen in both the columns. It is here as well as here. So they become a better treatment. Fine. Then in intrinsic sphincter deficiency, there is something else also, periurethral bulking agents and so on, which I will tell you towards the end of the class. This is how the needle suspension procedures were done. You don't need to learn it. This is a thing of the past, but just to give you an idea how it was done. Now this is what I want to show you. This is a open Birch surgery. Fine. Birch-Colpo suspension. Remember, the name of the operation is Colpo suspension. It is not urethral suspension, or it is not cysto suspension. You are not suspending the bladder or the urethra. You are suspending the colpos. What is the colpos? Colpos is vagina. So you are trying to pull just look over here. I hope you can see my cursor. So now you are looking from top. You don't have to open the peritoneum. You go into the space of Ritzius and do this dissection. The patient is in lithotomy position and one of my residents is sitting at the vaginal end. The assistant who's sitting at the vaginal end is doing a very important job. If she or he does not do a good job, I will end up doing an incorrect surgery, because she has to first catheterize the bladder and secondly lift that angle up between on both sides of the urethra to show me that look, this is the 1 minute. This is the urethra which is going, and on both sides this is the vagina. Fine, because I want to identify this area from top. Remember, now next time when you sit down to assist your professor in a Birch, remember this is the area what he or she wants to see, because this is the place where I want to take a couple of stitches this side and the other side. And where do I fix it up? I fix it up with the Cooper's ligament. There are 2 shiny ligaments, again, which you will see in a video. What is the suture material that you take? You take a non-absorbable suture. These are all exam questions. Those who've seen the surgery, you will obviously know it. Otherwise, you just remember it. Now what you do is when you pull this up, that angle gets elevated. That blue diagram and yellow diagram that you have seen, the sphincter again goes up because you have lifted the support. So this was the conventional Birch. Now what happened was, as the endoscopic surgery came, we started doing lap Birch, and in which there is a transperitoneal approach that you go transperitoneally with your laparoscope and do the same action. One benefit of this lap Birch is that simultaneously you can also correct any enterocele which is there from top. If you see that there is a lot of redundant space in the pouch of Douglas, you can close that redundant space so that she does not come back with a enterocy. Okay, so we have understood there is an open burst and there is a lap burst. Which one is more effective? Both are effective. We should not be under the impression that because we are taking the stitch laparoscopically, it will be less effective. No, it is not like that. And again, it is not I who is saying it. It is the people who have done research in this area. They say it along back with the statistics. Fine. So the results are comparable with open approach. Now, my dear students, please have a look at this video. Fine. So this is a endoscopy picture that you are seeing, and I will start the video. So now this is the assistant. This is one of you who's sitting at the vaginal end and pushing the vagina up. And here with this instrument, I just showed you where to take an incision. Now, what I am doing in this particular video is that I've got a scissor and the bladder is here somewhere. Fine. Why am I doing a dissection over here? Because I am trying to first reach for that Cooper's ligament. Fine. So I have done the dissection with a monopolar. I have dug deep and I have gone into both the areas on both sides of the midline and identified these shiny ligaments. I'll just show you once again. This is what I want you to see. Fine. I just made it still. So this is the IP ligament. Fine. Let us proceed on the other side. So we've done the dissection. Now this is my friend from the vaginal end who just showed me where to take the stitch. So I am taking a stitch from the Cooper's ligament, bringing it down, and the same place where I had shown you in that diagram, in the open burst, I am taking a stitch and elevating it up. Right? There you see that thing going up. Fine. So this is how lap burst is done. The same thing is now being done on the other side, and you just lift the colpose up. Okay. So this was what is lap burst. Fine. So open burst and a lap burst. One moment. Next slide. Yeah. Now, when would you do lap burst? So there are indications for doing when would you do a burst colpose suspension, open or lap. It depends on you. Both are good. If a patient is requiring concomitant abdominal surgery that cannot be performed vaginally, she's got some other pathology. So you put in a laparoscope from top. You treat her urinary incontinence. If there is a small cyst in the adnexa, take it out also. Both the things done in the same go. Fine. It should be performed only if the patient has adequate vaginal mobility and capacity to allow elevation and approximation of lateral vaginal fornices to the Cooper's ligament. When you were seeing that video, you were seeing somebody was pushing it up. Now, if there is a patient who's, let's say, had irradiation before, so there is no vaginal mobility, I cannot do this surgery. Fine. So patient has to have mobility, and the patient may be requiring a concomitant vaginal surgery. When will I not do a burst? Again, final years, viva question. When there is a fixed non-functioning proximal urethra, already told you, the burst procedure does not allow for correction of cystocele, rectocele or introital deficiency. So if all that is happening, there's a big cystocele also, there's a big rectocele also, which are problems lower down in the vagina. You cannot correct it from top. So it might as well operate vaginally and do an alternate procedure, which we shall just be discussing. Okay. So that is the story of burst. Next is the sling surgeries. This is very important, and I want all of you to focus on the next 5-10 minutes slides. Fine. So this is a normal urethra cross section. This is a urethra which is open in a woman who is incontinent. And this third one is a sling which has been put around it, which makes it closed. So that is the concept, broad concept. The story started in mid-90s when the first tape that we got was something known as a TVT, or tension-free vaginal tape. This is how this tape looked. So this is the tape, and both sides of this you find a big trocar which is sharp. These tapes are made of polypropylene and they are supposed to support the urethra. So what is expected is that if this is the urethra I will put my tape like this and lift it up. Let us see story further. So this I have told you. Now, initially what was found was that, okay, you give an incision in the vagina, and if this is the urethra like I was showing you, so you put a tape from below and bring it out in the suprapubic region. So it has made a U kind of support for it and cured the stress incontinence. But there is more to it. So this is how it was done. Some diagrams. The trocar that I was showing you, this is the direction in which it is supposed to go. And finally, when you have completed the surgery, this is that vaginal incision that I was telling you. You put the tape through and through, and it has come out in the suprapubic area. Same thing, if you see laterally, you will see something like this. So a U-shaped support. What are the problem areas? The problem areas was that the place where you were putting these trocars, there you could injure so many things. In fact, in this about 8-10 years period, they found, FDA reported 7 deaths. Now you imagine a death occurring because of a surgery done for urinary incontinence. Difficult to justify, right? There could be bladder injury, there could be bowel injury, there could be vascular injury, and last but not the least, overcorrection. I have been witness to these complications. TVT done today, Foley's catheter removed tomorrow, retention by the afternoon, third day, again Foley is put in the next evening, third day patient taken to the OT, TVT cut. Fine. That is not what we want to do. Why this retention was happening was because you were lifting it up. You were lifting it up. So what happened? Now, if you remember that anatomy we discussed in the beginning of our class, what did we say? We said hammock-like support. So we were looking for a hammock-like support. And this TOT gave us exactly that. It was a simplified technique, short procedure, less chances of complication, and the success was very good. Why all this happened was because it was physiological. It was giving it a hammock-like support. It was not lifting it up vertically like that. It was supporting it from the vagina like a smiley like this. Fine? Okay. Second, it can be combined with surgery for a pelvic organ prolapse. So this is that rectocele or big cystocele that I told you. You're operating from the vaginal end. To put a TOT, you do not have to go on top and do a burst. You can do it from the vaginal end only. So 2 birds killed with 1 shot. And it treats both urethral hypermobility and intrinsic sphincter deficiency. So this looks like something which is very, very attractive. Okay. Which mesh to choose? So the meshes are generally available in the market in packets like this. Fine. So you get a packet like this, inside which there is a long tape. There is a mesh. Now, you cannot use just any other mesh. So, you know, sometimes what happens is sister can tell you in the OT, hernia mesh, hey, I'll cut a piece of it and give it to you. Don't accept it. Fine. Because you can't put just any mesh. It has to be a synthetic and non-absorbable mesh. It should be monofilament and macroporous. No sharp edges, low elasticity, high stability, 10 mm in diameter, and should not roll on itself. My dear students of final year, please note these 5-6 points. You should know it for your future practice, also for your exam, that what kind of a mesh would you require. Fine. Now coming to transobturated tape. What are the complications which can happen? There can be voiding dysfunction. The chances are less. There could be some groin pain or dyspareunia. There are chances of mesh erosion, but far and few. Having learned the pros and cons, let us see how it is done. Some of you must have already seen it. Before I play the video, I want to show you this. Fine. So this is the needle that which is used to put a tape. The tape I showed you in a packet. It is this needle has got an eye over here. You thread that tape into this eye and do the surgery. Please have a look at this video and you will learn how it is done. Okay. So initially what we are showing you is a pelvis has been taken, and this is it is called transobturator space. So naturally transobturator tape. So it has to go through the obturator space like this. So that is just a teaching demonstration that where you think your needle will be going. Now, once you've seen that, what is done is that the patient is under anesthesia, bladder has been catheterized, and you put two LEs and hold the space of the vaginal wall below the urethra. What we are now doing with the finger is trying to palpate for the bulb of the Foley's. So you know that you are in the correct place. The bulb is likely to be at the junction of the bladder and the urethra. Once you identify that, you take a little saline or saline mixed with adrenaline and do a little infiltration as you do when you do a vaginal hysterectomy. Why this is done is because it gives you less bleeding and easy planes of dissection. After that, you give an incision which is about 3 centimeters long in the vagina. Remember, you have to identify the urethra. These are sub-urethral slings, mid-urethral slings, fine? So you have to put them below the urethra. After that, what I do is I take a scissors and I try to create a plane. I try to create a plane laterally. So you go laterally and you separate the wings of your scissors and sort of you separate it to create a plane. So now, having done the vaginal part of the surgery, we have to identify the site of incision. Now, this incision is to be given in the groin of the patient, the same thing being done on the other side. So we can sort of move it further. Now, this is the place which is being marked. Now, you don't have to mark it with a pen. That is because this is a teaching video. So what you do is that palpate the insertion of adductor longus, which is at the lateral border of the pubic tubercle. And from there, you draw a vertical line downwards. Then, from horizontally, from the level of clitoris, you make a horizontal line. The place where these two lines meet, that is the site of your stab incision. Same thing is done on the other side also. Okay, let us take it a little forward. So you've done this marking, and now, one moment. Yeah. So what I do is, I just take my knife and just a small little stab incision over there, fine? At the junction of these two vertical and horizontal lines. You put your finger in that same space which I had dissected with the help of scissors. Do you remember that? And then you take this needle. These needles are different for right and left, mind you. So you take this needle, you push it straight inside. You push it straight inside, and there is one finger in the vagina on which you try to feel the tip of this needle. Here, just focus here on this part of the video. So with the left finger, we are trying to palpate the tip of this needle. And what you will see is that this needle will emerge in that part on that incision which we had given. So here is the needle. It has come through that obturator space. Now what I will do is I'll take out the mesh which I just now showed you in a packet. I deliberately didn't open the packet because it costs money. We thread this tape into this eye of this needle and just pull it back. Just pull it back. So there you will see it will just be nicely taken out. In the meanwhile, while they are doing it, there are two techniques of doing this. One is a outside in technique and second one is a inside out technique. Depends on from which side are you pulling the tape. So on one side, the surgery has been done. Now we are going to repeat the same. It is just holding it with the artery forceps. The balance of it has been cut. We are now sort of repeating the same action on the other side and closing this small little incision in the vagina with a couple of stitches. Now once you are done with this, one moment, my fault. Yeah, I think we'll let it run only. I was trying to save some time, but the opposite happened. So this has been closed. This part I want you to see. You don't have to fix this mesh anywhere, right? You don't have to fix this mesh anywhere. You just take it over there and trim it. Just trim it. So this is gone. And this stab incision is so small that you don't have to put a stitch over here. Just put a little sticking tape, the ones you put on a port side incision, and she is good enough. So no stitch is required. Fine? Okay. Fine. One moment. Yeah. Now you have seen both TVT and TOT. This is a slide which has been made to make clear to you that what is the final picture. This is how a TVT appears. It pulls the tape up. Whereas TOT appears like this. It is horizontal. So this is that hammer. Again, on a specimen depiction of a TOT finally where it lies. Okay. What do you tell the patient after she's been operated? You tell her not to squat. You tell her about abstinence for a few days and tell her not to test. What is this testing? When a patient has been operated, it is natural that what she will do is she'll go home and she'll try to cough and sneeze and see if my operation is working or not. So please tell her not to do that. Why? Because how is your tape working? You didn't fix it anywhere. How it is working is that you have created this mesh over there, and in due course of time, there is fibrosis which is likely to occur along the tape, and that is what is going to give the support. Fine? So do not to test. Again, exam question for the final years. Between Burch Colpo suspension and TOT, one more thing, TOT is also called sometimes TVTO. So it is, if it is written TVTO, don't get confused, it is TOT only. What is gold standard? Burch was a gold standard for a long period of time. Even now, some authorities may like to hear from you that Burch is the gold standard. But let me tell you, my dear students, that there are standard, professional bodies, especially in Europe, which have now accepted TOT as the gold standard. So I hope that is very, very clear to you what I am saying. Now, the story has not finished with TOT. We have come out with single vaginal incision slings. And the needle is like this. This is the deployment mechanism. And this is the sling. In this, what is done is that there is no stab incision anywhere. There is no abdominal incision anywhere, nothing. Just a small incision in the vagina, a little tape pushed in this side, a little tape pushed in that side. And this is how it looks. But with this, we have to be cautious because the failure rate has been found to be high. The last diagram showing a comparison between TVT, which is a V like this, a TOT, which is more like a U, and a mini sling, which is like a smiley. Fine? So now I hope you understand why there are more chances of urinary retention and overcorrection with a TVT. There will be some patients in which this will not work. So in them, what we do is we have periurethral injections. You will require help from a urosurgeon for this unless you are well trained in urogynecology. And this is a cystoscope that you see along with the operative channel. And this is what we do, that there are periurethral bulking agents which are available, and through that operative channel, you go and create a few bleps so that this gap which was there, it becomes closed. And this is how it appears. This was the original urethra when you are seeing end-on. One injection, both side injection, and it becomes closed like this. The problem with periurethral bulking agents is they are costly, they are very costly, and they are not a permanent treatment. Fine? So it has to be repeated. Final word is artificial sphincter. Again, till now I have not had an occasion to use this, but these are for patients where your conventional surgeries, etc. have failed. So a sphincter can be given, and this little thing that you see outside is like a control in the hands of a patient. And how does this control work? It works like the control of an endotracheal tube. So there is one balloon outside, there is one balloon inside. So when the outside balloon is inflated, the inside balloon is deflated, the patient voids urine. Then again, she presses a button, the inside balloon gets inflated, the outside balloon gets deflated. This artificial sphincter stops the leakage. Okay. Now, having discussed this, because you guys have to write a theory answer also, so you should know that what new is happening in this field. People are trying to use lasers, magnetic stimulation, stem cell research is going on, dermal strips, because any artificial mesh which we use, there is always some chance of a erosion of the mesh. So people are trying to use this. Gene therapy, like everywhere else, people are trying to work here also. Tissue engineering and radio frequency micro remodeling. So these are the newer techniques. So with this, I think we have completed the treatment modalities. Before I finish, I would like to acknowledge some very important contributions. The first and foremost is from my professor and HOD, Dr. Aruna Menon ma'am, an eminent academician who's always encouraging us for all kinds of academic activities, and this is one of them. The second is Dr. Ashwath sir, who is a guru, who is a teacher, and from whom all of you learned so much, and from whom I have learned. And of course, Dr. Charmila ma'am, I didn't know your name before, so your name is not there on the slide, ma'am, but thank you so much for listening to this. Foxy, Dr. Alpesh sir, who gave me this occasion to join you, the sponsors of the event, and last but not the least, all my residents and all of you. And I want to introduce you to one fellow who's sitting with me. He is Vipin, my resident. I am technically challenged. I find doing a lab much easier than managing a laptop. So he did all that for me. Any queries that you may have, please tell me. Even later on, this is my phone number and my email ID. So where if you send me any questions, I would try and answer them.
Let this slide be there, sir. Let this slide be there. Anybody wants, let this slide be there. And we'll take, lack of time, we'll take few questions we will take anyway. Charmala will take. And first of all, salute to your passion. This is what taken in 2 hours. One of the best sessions. My mobile is full of thanking messages for arranging your class. So thank you so much, sir.
To you, sir.
I am getting the credit because of you, because everybody is so happy that okay, sir's class has been arranged and they were so what passion you have to teach for 2 hours.
So today,
now few questions we will take. Rest of questions I will send to you. Okay.
Absolutely.
Because of the lack of time. Charmila, a few questions which you have, Charmila will discuss with you, and rest we will send to you. Okay, Charmila.
Thank you so much, sir. I think we'll all agree that out of all the classes we have had till this time, this is one of the best. I think Dr. Ashwath also said the same thing.
That's a big compliment.
Yes, sir, it's because we have had such great teachers, but you have topped everybody. We didn't blink the whole 2 hours. I was sitting and watching. I'm not much into urogynecology, but you made me so interested.
I had a case. I wanted to go to hospital. But what I did was that I heard for 20 minutes and I told that case, let it be there. I continued hearing the whole because I will miss something. So I called all my PGs and I sent messages to them, don't miss this session, I told.
Thank you so much.
Anyway, madam,
so kind of you, sir. So kind of you, ma'am. I am really very happy to listen to you.
There are only one or two questions. And the first one is from Dr. Gauri, and she's asking, kindly repeat occult SUI.
Yeah. So, Dr. Gauri, see what happens is that in a patient who's got prolapse, fine. Normally what happens is that the anatomy is like this. If you are seeing from front, this is, let us say, the distal end. This is the proximal end. Let us say this is the anterior wall of vagina, fine. This is the vagina. So this is the vagina. This is the anterior wall. Above this is the urethra. Now consider this Foley's to be the urethra, fine? This is normal anatomy. And on top of that is the bladder over there. Now when the patient starts having prolapse, this is how the inversion takes place, fine? So now the urethra would have come somewhere here, where you see the cervix in a patient of prolapse. The urethra is going like that and getting turned. The patient has got a problem of prolapse, but because of this kinking, she is not manifesting the complaint of stress incontinence. Fine. How it will get manifested? If I just take a valsalum and reduce this prolapse. So the urethra and the bladder will come in their sort of normal anatomical position because you push the vagina inside. Now when she coughs, she will find that the urinary incontinence is there. If we do not diagnose it pre-operatively, we will do a surgery for vaginal prolapse and this patient will come back to us later on with stress incontinence. And because it was not manifest earlier, but got manifested either post-surgery or when you were evaluating it, we call it occult prolapse or a latent prolapse. Fine? It is hidden. Occult is hidden. When you reduce that prolapse, it became manifested. So that is what is occult prolapse.
There are lots of
Hope you
compliments.
understood?
Yes,
Yeah.
sir. Yes, sir. There are lots of compliments from Dr. Sindhumol, Dr. Gauri, Bharati, and there's one question like role of mirabegron for SUI.
Yeah. So the thing is that there are lots of drugs. There is tolterodine, there is mirabegron, and so on. Mirabegron is the latest, which is there for last few years. The problem is that lots of these drugs are actually helping patients of urge incontinence. Okay, they may have only some role in management of stress incontinence, and out of that, what sort of I can say is that the drugs which are available, duloxetine may probably still be the best choice. Fine, and there is a specific subset of patients who will require this pharmacotherapy, which I said while discussing the use on the slide, where you've done a surgery, she's come back after a few years, some symptoms, not a candidate for repeat surgery, not failure of surgery, mild symptoms, put her on treatment. Mild symptoms, not willing for surgery, not actually does not require surgery, try a pharmacotherapy. Fine, but usually the pharmacotherapy is more helpful in patients of urge incontinence as compared to stress incontinence.
There's one person who wants to know where to learn urogynec surgery after DNB.
You can go to any good center where a urogynecology is being practiced. You get in touch with us, you come over here. Fine, teaching is always open. Fine, it is just an open forum. So visit our OT, come witness the surgery. What I want to tell you, all you budding people, is that this procedure called TOT is it's a kind of a revolution. That such a common problem, so much misery for so much women. Simple procedure. You see 2-3 procedures being done, you can do it yourself, and you can change the life of that patient. Fine. So I'll tell you a story how women get hurt by this. I'll just take 1 minute, sir. Once one lady came to my OPD, well-educated lady, wife of an officer, senior officer's wife. I knew her socially. She entered the OPD, came down, sat down on the stool, and I asked her that, yes, what happened? And she couldn't speak. And then I saw that she's crying. So I was worried, what has happened to her? This lady had gone to a party, social gathering somewhere. So many guests, people are there. She's laughing and she sat down on a sofa and she leaked urine. Now, can you imagine how embarrassing that can be to a human dignity? Fine. And if you all learn this, you can, if you spread the word, so many more patients will come to you with this problem and you can make such an important change in their lives. Yeah.
There are people who are asking for sharing. Yes, sir. Yes,
sir. So this video, to those who have asked, this video of the class will be uploaded in the Foxy website soon. Yeah. So those who have missed also will be able to listen to sir again and again. It will be there till years in the Foxy website. So this will be a permanent, because anybody don't want to miss. Even I want to hear again.
Yeah. I want to see.
Really, anything I have missed, I want to hear again. So many compliments, sir. You cannot imagine the compliments which which is in the chat column. You can see the compliments which are coming. So thank you, sir,
I am grateful, sir.
for the wonderful session.
Sir,
We hope that we will be disturbing you again next year.
it will be a big pleasure, sir. Sir, I just want to say one line at the end before we sort of probably break off. Today, I was feeling like a very rich man. You know, there were about 200 residents listening. I could see the number of figure. So, what can be a bigger pleasure, sir, for a teacher? That so many people are sparing their time and making our effort worthwhile. And
sir, more people are listening in my hospital and all. In one big, they are projected, and they are all the residents are sitting and listening in a room. So so many places, so many. It's a double will be 500, almost 500 will be listening through YouTube and all. So many. It's only in Zoom, not only in Zoom. It is there. So many extra people are listening also.
Thank you so much.
So thank you so much. Thank you all. Thank you, Charmila, especially. Thank you all postgraduates. We will be Thursday again. We have screening in pregnancy, another important topic by Rohan Palshetkar. So be there. Don't miss the sessions. Be there. And thank you, Anvik also. And thanks once again.
Thank you so much, sir. Thank you, madam. Thank you very much.
Thank you.
And sir, please convey my grateful thanks to Dr. Alpesh, sir, and the other office bearers of Foxy for giving me this chance.
Thank you, sir.
Okay, done, sir.
Thank you, Ashwat, sir. Thank you so much.